Hello everyone, my name is Zaman. I am third year Mbbs student. So I would like to discuss gastric adenocarcinoma to my fellow brothers and sisters, whoever is watching this video, and my dear friends. So the etiology of the gastric adenocarcinoma goes with H. pylori infection, Epstein-Barr virus, and the nitrites. You will be thinking how the H. pylori infection is causing this gastric adenocarcinoma things. As we all know, or we will know, that H. pylori infection causes gastritis. So the chronic gastritis will lead to this gastric adenocarcinoma. Here we are mentioning Epstein-Barr virus, right? So Epstein-Barr virus positive tumors mostly affect the proximal part of the stomach. And coming to the third etiology, that is the nitrites. So nitrites, what is nitrites here? How is it linked with? So we have to know something, that there are some bacteria in our stomach that converts nitrates into the nitrites, right? So from where the bacteria came to our stomach, that's the main question. So if we'll see in the low socioeconomic classes, the diet is contaminated with the bacteria. Also in the case of atrophic gastritis, pernicious anemia, and the decreased gastric acidity condition, or the enterectomy patients, what happens that whenever after consuming the dried or smoked or salted foods, they basically contain nitrates. These kind of foods contain nitrates. So that is being converted into the carcinogenic nitrates by the bacteria, right? So these carcinogenic nitrates is leading further to the gastric adenocarcinoma. Now, coming to this is the very important flowchart which I have taken from the Ramdas Nayak, and this all notes which I have made is from the Ramdas Nayak. Now, this flowchart clearly tells us how the H. pylori is behind all this thing, right? So see, here chronic means it's a very long period of time, more than 6 weeks, right? The H. pylori infection is there, and that is leading to the chronic inflammation of the gastric mucosa, leading to atrophic gastritis, right? Now there is atrophic gastritis, there is a chronic inflammation, so this will cause the decreased secretion of the acid, that is hypochlorhydria, right? And also the pepsin will be decreased. The pepsin synthesis or secretions is decreased. Now what happens, since there is in hypochlorhydria, right, the HCl prevents from the bacterial growth, right? So further it will favor the bacterial growth and also growth of the bacteria that convert nitrate into carcinogenic nitrate, right? And thus the chronic inflammation will be continued, further causing the progression of the mucosal atrophy and leading to the intestinal metaplasia, means the cells over there in the stomach is replaced by the intestinal epithelium. This is called dysplasia, right? And leading to the carcinoma stomach. So dysplasia means the presence of cells of an abnormal type within a tissue, right, which may signify a stage preceding the development of cancer. So here we are with the pathogenesis of the gastric adenocarcinoma. So we are dividing our study of the pathogenesis in the two category. First is the familial gastric cancer, and the second one is sporadic gastric cancer. Now, what is familial gastric cancer? What's happening there in this pathogenesis is that there is a CTH1 gene mutation, and this CTH1 gene synthesizes or forms the protein E-cadherin, which helps the cell to bind together. So the cadherin, CDH means cadherin, right? So this cadherin helps in the E-cadherin helps in the cohesion. Now coming to the second part, sporadic gastric cancer, that we are dividing into the diffuse and the intestinal type gastric carcinoma. Okay, so first we will see the sporadic diffuse gastric carcinoma. What's the pathogenesis of that? So what happens is that again here cadherin 1 gene mutation is happening, means there is a loss of the E cadherin, means the cohesion between the cells are lost, right? Now the CDH1 promoter, there is a region in the gene, there is a promoter region which is going to be hypermethylated and there been silencing is happening. So because of these two phenomena, again there is a decreased expression of the E cadherin. Also, it has been seen that the people having BRCA2 mutations, they have an increased risk of diffuse gastric carcinoma. And remember this, that TP53 mutation is also liable for the gastric adenocarcinoma, not only for the diffuse but also for the intestinal type, right? Now coming to the sporadic intestinal type gastric carcinoma, we will deal first with the APC gene mutation. What is APC? APC stands for adenomatous polyposis coli gene. So what happens that, see, sometimes if you have studied in a plus 2 or some like there is a mutation, right? The mutation can be beneficial and or it can be a loss for us, right? It can be gain also, it can be loss for us. So here APC gene mutation is creating a loss of function, right? So because of this, what's happening, there is an increased signaling via WNT pathway, and due to increased signaling via WNT pathway, this gastric adenocarcinoma is occurring, taking place. Now the second is beta catenin gene mutation, but this mutation is a gain of function. Also again the TP53 mutation, which was also there in the diffuse type, right? And BAX gene and CDKN2A gene mutation, but here again this mutation is a loss of function mutation. So these are the pathogenesis of the familial and the sporadic. And the sporadic we studied diffuse and the intestinal type, right? Now coming to the morphology, which is the very important part in any pathology topic. So morphology, if we will discuss, it's here that site means where it's have occurring in the stomach, right? The gastric adenocarcinoma. So site in the 50 to 60% of the cases pylorus and antrum. 25% cases it's cardia and 15 to 25% it's body and fundus. Also, if you will see whether it's lesser curvature or greater curvature involved, so it's a lesser curvature. Now, the very important classification which we will see here, I have taken this from Ramdas Naik again, based on the macroscopic growth pattern. So here are three patterns which we will come across. First pattern is type 1. So type 1 is an exophytic, or you can say it polyploid or also fungating, right? It is a solid tumor which projects or protrudes into the lumen as a polyploid or nodular mass. So the important thing to notice is that it protrudes into the lumen. Which lumen? It's the gastric lumen. As here you can see in the diagram that this is the first layer is the mucosa, then submucosa, the muscularis and the serosa. So it's protruding in the gastric lumen. Coming to the second type, it's a type 2, flat or depressed. So here we will come across three subclasses, that is type 2A, type 2B and type 2C. In type 2A, there will be a slightly elevation we will see. In type 2B, there will be a flat lesion. And in type 2C, it will be a slightly depressed lesion. And remember, with no obvious tumor mass within the mucosa is the characteristic. So here this is a type 2A which we are seeing, it's a slightly elevated. This is type 2B, flat, and this is type 2C, slightly depressed. Now coming to the type 3, that's also known as excavated. So it is basically characterized by a shallow or deeply erosive crater in the wall of the stomach. An excavated malignant ulcer does not ordinarily occur alone, but rather represents ulceration of type 1 or type 2 tumor. So since it is an ulcer, right? So ulcer has a base is there, So okay, the margins are there, right? Edges are there. So if you will see here, the mucosa surrounding the ulcers are very firm. It's raised and nodular. But the margins, if you will see, it's a heaped up, beaded, saggy, and irregular. But the base is necrotic and ragged, right? So this is here the type 3. Now we will be moving towards Laurent classification. That's one of the very important classification. It's a microscopic classification. So we will be dealing with the intestinal type and the diffuse, or you can say it's also as an infiltrating gastric adenocarcinoma. So I have made a tabular form, okay, for the intestinal and the diffuse gastric adenocarcinoma, but I will be dealing with this one by one. So first we will be dealing with the intestinal type. So this is the intestinal type. What happens in the intestinal type? Let's see the gross. Gross is polypoid bulky tumor or ulcerated. Already we have seen polypoid. It's what? It's in type 1, right? That is protruding into the. So the intestinal type is a gross polyploid bulky tumor or ulcerated. Site where you will find it in the stomach, it's antrum and the lesser curvature. Already told lesser curvature is more involved compared to the greater curvature. Now microscopy. Microscopy, it's written that cohesive tumor cells, right? This is very important. That the tumor cells have the cohesive property, right? And due to that, they have formed a gland-like tubular structures, right? Resembling adenocarcinoma of colon. The important feature of the tumor cells, you will see there is an apical mucin vacuoles, right? And the mucin may be present in the lumen of the glands. So this is the diagram I have put, okay, for you all that. If you will see, this is the intestinal type, right? So here is the apical mucin vacuoles, right? In the apical you will see the mucin vacuoles, and also sometimes the abundant mucin may be present in the gland lumina, right? And if you will see the morphology in the intestinal type, you will see the bulky tumors frequently grow along broad cohesive fronts to form either an exophytic mass or an ulcerative infiltrative tumor. You can see here in the diagram I have put, right? Now moving to the second one, diffuse or infiltrating gastric adenocarcinoma. Gross. The gross is it infiltrates deeply into the stomach, no mass lesions like it was there in the intestinal type. Here you will notice a desmoplastic reaction. What is desmoplastic reaction? It's very important to note that the growth of fibrous connective tissue around tumors known as a desmoplastic reaction. So because of this, diffuse flattening of the rugal folds in mucosa and rigidness, and that is rigidity and thickening of the wall takes place, causing to the formation of non-distensible stomach, and lumen is narrowed. So because of this, we see leather bottle appearance called as a linitis plastica. In the microscopy of the diffuse type, you will notice that there is a discohesive tumor cells that do not form glands. The tumor cells have abundant mucin. Because of this, the cytoplasm expands and pushes the nucleus to the periphery, and this gives signet ring appearance to the malignant cells. Remember, if the signet ring cells constitute more than 50% of the tumor, it is classified as signet ring cell carcinoma. So I am going to show you the signet rings appearance of the malignant cell. See, this is the diffuse type. They are signet ring. Okay, you are seeing the ring, right? And you see these are the cells. These are the cells. Signet ring form cells are there, right? So they are large mucin vacuoles that expand the cytoplasm and push the nucleus to the periphery, giving them the signet ring. Also we talked about diffuse type. It's not bulky, it's an infiltrative and evokes desmoplastic response. That is very important. Desmoplastic response is very important in the formation of the linitis plastica that stiffens the gastric wall, and is also known as leather bottle stomach. Large areas of infiltration, diffuse rugal flattening. The rugae are flattened and there is a rigid thickened wall. So this is the right side, rightmost side is the leather bottle. Then how this is how our stomach looks in such condition, right? So my friends, I think up to this I have told you the etiology the pathogenesis, some classifications, their gross and the microscopic features. I hope that it's clear for all of you guys. Now coming to the most important thing, how does it spreads? How the carcinoma stomach spreads to the other parts of our body. So any spread we write under the headings local or direct, lymphatic and the blood spread. In the local or direct spread, we see the local or direct spread occurs into the muscularis or serous of the stomach, and it can invade the duodenum, pancreas, liver, colon or the retroperitoneum. So in the lymphatic spread, it spreads via the submucosal and the subserosal lymphatics, right, to both the regional and the distant lymph nodes. Okay, so if you will see here, one is the common, that Virchow's node, right, also known as a Trossier's sign. So this gastric adenocarcinoma spreads to the supraclavicular sentinel lymph node, right, that is on the left side. On the left side, it is the Virchow's node also we say it, and it is the first clinical manifestation, okay, in this case, right. Now something is known as a Sister Mary Joseph nodule. So you will also see a Sister Mary Joseph nodule. This is basically when the tumor metastasizes to the periumbilical lymph node. Okay. Now coming to the Krukenberg tumor, already we know this, like we studied in the first year, that breast cancer spreads to the ovary. Same similar thing is like metastasis to the ovaries, right, is called a Krukenberg tumor. And we see here a Blummer self when the metastasis is to the pouch of the Douglas, that is known as a Blummer self, right. So whatever I have mentioned, like Blummer self tumor, iris node, Krukenberg tumor, Sister Mary Joseph node and a Virchow's node. I have missed the iris node. So iris node is a metastatic spread of the gastric cancer to the left anterior axillary lymph node. So everything is here in this summary table. You can take the snap of this if you want. Now coming to the third, blood spread. And the blood spread, it spreads via the portal vein into the liver and also to the other sides, sometimes in the lungs and bones also. Now I have taken this snap from the snag of the clinical features. So already first all of you have seen just now that it's a Trossier's signs, right. Metastatic lymph nodes may be palpable in the left supraclavicular fossa, yes or no. It is Virchow's node is also known as Trossier's signs, right. Now some clinical features, like you will see, the early satiety means after even with a small meal, right, having just 1 or 2 bites, 3 bites, like not 1 or 2, I am telling you, having a small part of the meal itself, the person will have a feeling of what, fullness, right, that's called early satiety. Then bloating will be there, distension and vomiting are there, right. And remember, this tumor bleeds frequently, right. So because of this, already you know that it will lead to the IDA, so iron deficiency anemia, right. Now also important that if this is present near the pyloric region, if this tumor is present near the pyloric region, then it may present with the gastric outlet obstruction also. Okay. Now coming to the Trossier's sign. So this is Trossier's sign is the non-metastatic effects and may be in the form of migrating thrombophlebitis. Okay. And also as a deep vein thrombosis. These are due to the effects of the tumor on thrombotic and hemostatic mechanisms. Okay. So I will show you some pictures of the clinical feature, okay, and let's see. So guys, this is the migratory thrombophlebitis, Trossier's syndrome, okay. This is you can see here, okay, how it is associated. So since it's in the figure, it's associated with the pancreatic cancer, but it can also be associated with the gastric cancer also sometimes, right. Now, so it is a disseminated cancers or certain types of malignancies such as a pancreatic or you can say gastric adenocarcinoma, right, okay. It's associated with the repeated attacks of the multiple venous thrombosis at different and changing sites due to the procoagulant factors formed by cancer cells, right. And this is referred to as migratory thrombophlebitis or Trossier's syndrome. So I have a picture for you for the Trossier's sign also. See, you can see here the lady is having this Trossier's sign here, you can see, okay, we can appreciate it, okay. So this is enlargement of the left supraclavicular lymph node and is considered a sign of metastatic abdominal malignancy usually seen in gastric carcinoma, right. And this enlarged supraclavicular lymph node is known as Virchow's node, Trossier node, or you can say as a Virchow-Trossier node too, right. Now we have discussed regarding the spread through the lymphatics, right, which this is the Sister Mary Joseph nodule. Okay, you can see this. So that's the end. Not that not it's not the end. Some we have also the comparison with the benign in the malignant. Let's see. So guys, we have arrived in the last segment of our video. So we will be discussing the differences between the benign and malignant ulcers of stomach. So this is again I have taken snap from the Ramdas Nayak pathology. So here benign ulcer and malignant ulcer. So if you will see the age benign ulcer is taking place usually in younger age, right? And the malignant ulcer is happening in the older age. The duration of symptoms is weeks to years in the benign, and malignant it's weeks to months, right? Okay, and the location or usual site is lesser curvature of the pylorus and antrum in the benign, and in malignant case it's greater curvature of pylorus and antrum. So see, malignant is happening in older age, right? So obviously greater and lesser, so it will be having occurring in a greater curvature. Like that you can make a trick also. And in benign is younger, so it's happening in a lesser curvature of the pylorus and antrum. Pylorus and antrum is both same in the okay, in both the case, right? Now coming to the gross. In the gross if you will see size, right? In the size benign again it's small and the malignant is large, right? The trick is continued, yes or no? Now shape, if you will see the shape, it's regular in benign ulcer and irregular in the malignant ulcer. Now surrounding mucosa, it's the mucosal rugae projects outwards from the margins of the ulcer, whereas in the case of the malignant, the mucosal rugae stops far off the ulcer and shows flattening. So you will observe the flattening in the case of the malignant part. Now if you will see the floor of the ulcer, it's clean in benign and necrotic in the malignant. And if you see the margins are overhanging like spokes of wheel and heaped up and everted in the malignant. While in benign it's overhanging like spokes of wheel. If you will see acidity, it's normal to low in case of benign, but in malignant it may show achlorhydria. So guys, I have a picture for you. The benign gastric ulcer, this is the benign gastric ulcer, you can appreciate here. Here you can see how the mucosal rugae projects outwards, right, from the margins of the ulcer. And if you will see here in the malignant ulcer, the mucosal rugae stop far of the ulcer and shows flattening, right? The flattening you can see here. So this is what I was talking about, right? You can see the stomach spoke wheel pattern, right, in the case of the benign ulcer, overhanging like spokes of a wheel, right? So here we were talking about benign gastric ulcer, right? So benign gastric ulcer, if you will see the mucosal folds, it's converging folds, right? You can see in the diagram also, and the margin is regular, okay? Floor is the granulation tissue is in floor, and if you see the edges, it's not everted or it's a punched, right? Now surrounding area is normal and the size and extent is small deep up to the muscle layer, right? Now if you see the malignant gastric ulcer, its mucosal fold is effacing the mucosal folds, right? The margin is irregular. Now floor is having a necrotic slough in the right floor. Now edges are everted and the surrounding areas are showing nodules, yes or no, ulcers and irregularities. If you see the size and extent, it's all is actually a large and deep, right? Here you can appreciate in the diagram, it's the stomach spoke wheel pattern that is seen in the benign, right? Here are some endoscopic images. The A1, this which you are seeing, is a malignant ulcer, right? And this diagram, this image, right, it's related to the benign ulcer, right?